It's my pleasure to introduce Irene Burger. Irene is a doubly board certified nuclear medicine physician and radiologist working in Baden and Zurich and specialized in prostate cancer imaging. She spent a research fellowship at Memorial Sloan Kettering in the US, and she will talk now about primary staging of prostate cancer with PSMA PET. Please, Irene.
Thank you very much, Klaus, for the introduction, and also Ali for preparing the stage so well. So PSMA PET really changed imaging in prostate cancer. We all know that. The most common application, of course, is biochemical recurrence. But I think the age is now there to also implement PSMA PET for staging. And I'm happy to be able to show you in the next 25 minutes why I think that this really will bring benefit to our patients. What you see here are really the first patients imaged with PSMA PET MRI in Zurich without any pre-selection or any patient that has been left out. And you see the nice uptake of PSMA in the dominant lesions of all those patients with various intensity for sure. So that brings me to my disclosures, what I do not have, and then I would like to show you what I'm going to present in the next minutes. First, I would like to talk about the role of PSMA PET for staging. So where does it help for local extent, lymph nodes, and for bone metastasis? And in the second, shorter part, I would like to present some data about the role of PSMA PET for really tumor detection and not only staging of high-risk cancer. So when we talk about staging high-risk disease, there are three features, of course, that are most important. First, the local extent, then the nodal extent, and of course also the detection of distant metastasis. That brings me already to my first poll question. I brought you two images. There are axial images, T2 weighted MRI, and a fused PSMA PET MR. And the question is, what do you think? Does patient 1 have seminal vesicle infiltration? Does patient 2 have seminal vesicle infiltration? Do both have? Or do you think that this is no infiltration and just an artifact? Okay, so please vote. Do you think that there is seminal vesicle infiltration in patient 1, in patient 2, in both patients? Or do you think that this is an artifact and that there is no seminal vesicle infiltration? I hope you had enough time to actually see the image. So I see that most of you actually thought that if it looks that clear, it must be a trick. Indeed, this is the same patient, and what you see here is the increased PSMA uptake in a seminal vesicle infiltration that is really barely seen on the MR. Having had some of those cases, we thought that it would be worthwhile to investigate whether we have some evidence that really PSMA could improve local extent decision. And we investigated this by doing an analysis in 40 patients that had a multiparametric MRI and a PSMA PET MR. And in fact, these were 4 radiologists that just got a 30-minute crash course how to read a PSMA PET, and they outperformed using PSMA PET MR, the multiparametric MRI for both extracapsular extension as well as seminal vesicle infiltration. Now, the resolution of PSMA PET is not as good as of MR, for sure. However, the PET just helps you to really know where the dominant tumor is and to look very closely in this area. And that, in fact, really improved the overall investigation of the radiologists when they had the additional information of the PSMA. By now, we have further support for this finding. There was a meta-analysis in 615 patients performed by Wu et al. It will be published soon. And what you see here is that compared to a meta-analysis with over 9,000 patients, indeed, the sensitivity for extracapsular extension and seminal vesicle infiltration improved when you have PSMA PET compared to multiparametric MRI. And of note is that here we even have PET and PET-MR, PET-CT. If you look at the PET-MR data only, this increase in sensitivity is even more prominent. So yes, I think PET can help also for local extent. So if you have a PSMA PET-CT and a multiparametric MRI side to side, look at both to investigate whether the patient really has a T3 situation or not. But the most important factor or the most important reason to do a PSMA PET, of course, is not the local extent, it is the distant disease. That brings me to the next question. What do you think is correct regarding patient-based sensitivity for nodal metastasis? Do you think that anatomical imaging ranges around 10 to 20% in sensitivity? Do you think choline and PSMA PET is more or less equal? Do you think nomograms that predict lymph node involvement are more or less equal to PSMA PET? Or do you think PSMA is that good? If you are negative, you can spare a pelvic nodal dissection. We have about 56%, 57%. Just get a wild guess. Okay, so I see you are all PSMA believers. I wouldn't go that far. If you have a negative PSMA PET, you still can have nodal disease. So PSMA PET has a sensitivity of around 60%. This is clearly better compared to anatomical imaging, but it's not as bad as 10 to 20%. And the right answer here actually is C. And I will show you what I mean with the nomogram for lymph node involvement. So we all had those cases. You have lymph node detection done in the past with choline PET. This was a man that was actually staged with choline in an outside hospital and then referred for prostatectomy, being negative in nodal disease. The PSMA PET that was performed just a month later in our institution then unfortunately showed not only a large and very PSMA-avid primary tumor, but 4 nodal metastases in the iliac region. So the clear improved sensitivity between choline and PSMA not only holds true in early biochemical recurrence, but also staging nodes. This has nicely been shown by a publication from Frederick Giesel, where he looked into the size of the nodes and the uptake. And if you see how many lymph nodes are actually below 8 millimeters, it becomes very evident that anatomical imaging is going to miss all those nodal metastases, while PSMA actually in this cohort would have been missing just 1 lymph node with an SUV below 3. That was selected as a cutoff in this publication. Now, it's with more and more data, I think you start to learn that you also miss things. In our own experience of 60 patients we analyzed with RPE, nodal dissection, and PSMA PET, we came up with about 85% of detection rate. We also saw that the nodes that were missed were very small, so lymph node metastasis usually smaller than 4 millimeters. This is in alliance with data also from Germany. In 130 patients, they also came up with a sensitivity of about 65% of PSMA PET on a patient base Morphological imaging was around 40%. So it's higher than 20%, but of course it is far lower compared to PSMA. Now, this 60% is actually quite similar to the so-called lymph node prediction nomograms. Nomograms are commonly used still by the urologists to make a decision whether a patient should undergo pelvic nodal dissection or not. If the group from Munich nicely compared the sensitivity of those nomograms and came to the conclusion that they were actually just about as sensitive as the gallium PSMA PET. However, the PSMA shows a much higher specificity, so clearly in favor actually of imaging. Furthermore, the PET has the advantage that it can localize the nodal disease, what sometimes is really altering also surgical approaches. So having said that, the question is really, can we further improve this 60%? And I think we can, because by now we know that PSMA is a very, very good predictor of aggressive disease. So why not taking the PSMA information into account and building a new model to really predict nodal disease? We did so, and when we added the information about PSMA total to the clinical data, we could generate a model with a higher prediction for nodal disease compared to the just clinical nomograms that have been published in the past. What is actually really interesting also is if you look at this graph, the decision curve analysis, it is irrelevant of the risk threshold you choose. The model using PET data and clinical data always outperforms in the prediction of nodal disease. Now, a model with 60 patients is, not really what you should do. That's why we further validate this data in a larger cohort. The results so far look promising, and I'm confident that we can show them soon. This brings me to the next question. This is a 63-year-old patient, had radiotherapy, then colon positive nodes, got radiated them again, and now he has a rise of PSA. We see two prominent lesions here. And my question is, do you think that these are two lymph node metastases, that this is a lymph node metastasis and an urinoma, a lymph node metastasis and a bone metastasis with mismatch, or that these are actually two neurinomas? Please vote. Okay, so I see that actually A and B got switched. And of course, the majority is right. These are not two lymph node metastases, but it's a lymph node metastasis and a urinoma. And why am I convinced that this is not a lymph node? It's the location. And Ali already showed you very nicely that the classical positions of the ganglia very often are those linear teardrop-shaped PSMA uptakes, but along the areas where you usually just expect neural structures and no lymph nodes, be very careful to call those lesions lymph node metastases. In this patient, I ordered an MRI with the suspicion for a urinoma of the nervus suprascapularis, which actually was confirmed, and the single lymph node metastasis could be irradiated. This brings me now to the bone metastasis. Bone metastases, commonly imaged with bone scans, are very commonly false negative. We all know that. The sensitivity of bone scans is very, very low, especially if your PSA value is still below 5. So This patient actually had a high PSA value. Nevertheless, negative bone scan, large tumor on the MR, was referred for prostatectomy, got a PSMA PET CT that actually showed 4 bone metastases and lymph node metastases. So the patient was not a candidate for local surgery anymore, but local radiotherapy and systemic treatment. Now, there are not too many analyses that really go deep into the sensitivity of bone metastases, comparing them with multiple different imaging modalities. One I really like compared the PSMA PET CT with fluoride PET CT as a superior bone scan and with whole body MR. And what you see here is that the rate of true positives was definitely significantly higher for PSMA PET compared to whole body MR. What I like about the study, they did not only look into positive or negative patient-wise results, but also did the scan distinguish correctly between a patient that has no disease, limited disease, or extensive disease. Extensive disease in this case was more than 5 metastases. And what you see clearly is that the PSMA PET made the best and the most accurate labeling of the patient into those 3 groups, while fluoride actually mislabeled 6 patients and whole body MRI mislabeled a lot of patients that actually didn't have any disease with positive or suspicion for bone metastasis. So they concluded that PSMA PET was significantly better than whole body MR, but that there was no significant advantage compared to fluoride for bone metastasis. But let's not forget, this is only bone, and we don't see anything in the lymph nodes. So with this, we have also to mention that all this data is correct for gallium PSMA. And as Ali already mentioned, the bone situation for fluoride PSMA 1007 is not so well established yet. Here you have a patient with a clear bone metastasis, high uptake on the PSMA. It got radiated, and the patient had a good drop of PSA for almost 2 years. Now the PSA was rising again. He gets a second scan, and as we also switched for most of the patient, now he has a fluoride PSMA 1007. So with the increase in PSA now to 1, we have 1 lesion, again very sclerotic with high uptake. But we also have several lesions in the ribs. One of them was actually really prominent on PSMA PET, but there is no morphological change. So I doubt that this actually is a bone metastasis, because all his bone metastases always showed really strong sclerosis. And I think this is really something we will have to investigate further. But having said all that, we cannot talk about PSMA and staging when we don't talk about trial Michael Hoffman did in Australia. I think this really brings all the data very nicely together. They investigated patients with high-risk features. And I think the notion of high-risk features here is important because they included all patients with an ISO grade of 3. This means as soon as you have a 4+3 Gleason score, you are considered high-risk feature in this cohort. And I think this is really important because also the European urology guidelines suggest that you should do staging with cross-sectional imaging if you have an ISO grade of 3 or more. So let's not forget the patients with a 4+3 and just do PSMA PET for the high-risk patients according to D'Amico. In this population, Michael Hoffman confirmed all the things we already know from the PSMA PET from retrospective analyses. You significantly improve the accuracy, especially by having a much, much higher sensitivity for any metastatic disease, for the nodes, and also for bones. But they also gave us some very nice additional results, especially the radiation. You have less radiation exposure actually if you do a PSMA PET compared to conventional imaging with only below 10 versus 20 millisievert per patient. And you have a higher impact on management. And actually this 28% is an interesting number because we came to a very similar number. We had 116 patients scanned in Zurich and investigated in how many patients we actually changed the modality and in how many we just did some modality detail change. And overall, we also saw that in 27% of the patients, we really had an impact with the PSMA staging. Now, impact on management is nice, but you really also want to improve the outcome of the patients. And knowing that PSMA PET has a higher detection of distant disease, you would expect that if you use PSMA PET for the selection of radical prostatectomy, then you also improve the short-term outcome, meaning the PSA persistence after 6 months. And yes, you do. We selected a control group of 53 patients and a PSMA group of 52 patients. And what you see is that there was a significant lower number of patients with PSA persistence in the PSMA group compared to the control group. We had furthermore also more nerve-sparing surgery and a higher rate of R0 resections. This is still under revision. So, for tumor detection, I think that PSMA is a very interesting tool to really go even earlier. This has been shown in a very famous publication by Iber et al. That just the addition of PSMA to the T2, you actually improve multiparametric imaging significantly. These retrospective analyses, however, are tricky because, of course, you do not do PSMA for patients with low-risk disease. So this data is always looking at patients with already known high-risk prostate cancer because this was the pre-selection to do a PSMA PET. We had some cases where MR didn't show anything, the template was positive, and indeed we could localize disease with PSMA PET MRI. And this was leading us to the idea that we could actually use PSMA PET MR for biopsy guidance and to see whether indeed really PSMA can improve cancer detection over multiparametric MRI. So that was the principle. You do a PSMA PET MR, you fuse the image so that you get a DICOM data set, you bring this to the operating suite where they get the template biopsies. The surgeon is localizing the disease and targeting the lesions that we labeled as positive. And indeed, if you look at the accuracy of PSMA positive lesions versus PSMA negative lesions and the correspondence with significant cancer in red and no significant cancer in blue, it is really quite eye-opening if you compare this to the PIRATES classifications. We all knew that PIRATES 3 sometimes is false positive, but that PIRATES 4 is false positive in so many cases was a surprise to me. And this is, I mean, definitely preliminary results with just 42 patients, but I think it's worth further investigation, and I also think we should have a close look at those 4 cases that actually something was wrong. So we had 3 false positive lesions when comparing to the template biopsies and 1 false negative. Looking at the immunohistochemistry of the 3 false positive patients, we actually could confirm nicely disease in the posterior area where we actually had the PSMA uptake, and on prostatectomy here, significant disease was confirmed in each and every patient in nice correspondence with actually the PSMA avid area on PET-MR. So maybe template biopsy is not a perfect gold standard. There was 1 false negative case. Yes, we have a clear dominant lesion with diffusion restriction, but no PSMA on immunohistochemistry. So we are not going to catch all the tumors, but I think we have a chance to really improve over multiparametric MRI with PSMA in certain patients. That brings me to the last question. This is a 62-year-old primary staging prostate cancer. He has a PSA of 7.7. And I show you the coronal T2 weighted with the fusion, the axial PET, and also the axial fused PET-MR. And my question is, do you think that this is bilateral cancer, an artifact from the bladder spillover, physiologic uptake in the central zone, or bilateral prostatitis? Okay, so most of you thought, okay, that's too hot, that's got to be cancer. And I fully understand this interpretation. Actually, I thought the same in the beginning. What you see on the coronal image is that there is this bilateral ear-shaped darkening on the T2, and that it's very symmetric, and that it is the central zone and not the peripheral zone. And indeed, the central zone can really be very, very PSMA avid. We actually investigated this and looked at the SUV distribution in the 3 areas of the prostate. The peripheral zone, which indeed usually has a very low PSMA accumulation. In the transition zone, where you indeed sometimes can already have some increased uptake, and in the central zone. And the central zone really sometimes sticks out and nearly looks like a lesion, also can have PSMA uptake up to 5, or as the case you've just seen before, even higher than this. And that's what we call the hot ears of the Mickey Mouse. So when you use PSMA PET for staging, be sure that you don't get fooled by the central zone. If it's symmetric, if it has this ear-shaped T2 feature on MR, then you should not overcall the central zone. And with this, I would like to thank you for your attention, and I'm curious for the questions.